the possibility to conduct this webinar. So today the topic is TTV-guided immunosuppression, and I will directly dive into the clinical problem. So after kidney transplantation, and especially in this modern era of personalized medicine, the holy grail is to find the best individualized, personalized immunosuppression. On the one hand, we want to have enough immunosuppression preventing allograft rejection, and on the other hand, we want to minimize over-immunosuppression coming with an increased risk for infection or other side effects. So what would be very beneficial would be a tool, a gadget, or a so-called immunometer, which really can indicate us the risk for rejection due to low immunosuppression and the risk for infection due to high immunosuppression. And this is a very interesting question, and there are several groups all around Europe working on this question. And I like to start with one other example published here in this study. This was a randomized controlled study conducted by the group in Essen, led by Professor Pape. And this study was conducted in the field of pediatric kidney transplant recipients. And they had a very interesting assay to guide their immunosuppression. And what they have done is quantifying virus-specific T cells. And then according to this T cell count, they guide the dose of the CNA or mTOR-based immunosuppression. And in the control group, they only looked at the standard through levels. And in this trial, the follow-up time was the first 2 years post-transplant, and the primary outcome was renal function after this time. And what they have found was that there was no difference in the eGFR after the 24 months post-transplant. So they have reached their non-inferiority endpoint. But what was really interesting on the other hand is that they have reached this endpoint with a significant reduction of their immunosuppressive drug exposure. So they have the same renal function with less immunosuppression. On the other hand, you also could see that the allograft rejection seemed to be lower in the active group, but it has to be said critically that both rejection rates were quite high for this type of transplantation. So this is a very interesting, innovative idea, but I think this assay really needs very specialized laboratory, specialized training. So it might be problematic in terms of implementation, standardization, and availability of this immunological assay. So let's go to the other innovative candidate, which is a TORC-tinovirus, TTV. What is TTV? What you can see here on the left side, it is a single-strained DNA virus coming from the family of the adenoviruses. Nowadays, we know about 20 subtypes in human, and this virus was first discovered in the end of the 19th. So we only knew it now for around about 30 years. But since then, we have seen that the prevalence of this virus is very high. Already in healthy population, up to 90% are infected with TTV, but especially in immunocompromised cohorts, like after kidney transplantation, the prevalence is even higher, up to 99%. In our group here in Vienna, maybe 1 of 100 is not infected with TTV. The route of infection can be almost any, and the infection mostly occur in the early stages of the individual life. The replication of TTV can be everywhere, but mostly TTV replicates in leukocytes or hepatocytes. But since we know TTV couldn't be associated with any kind of disease or clinical picture. So we don't know, or we know that TTV causes no disease, or this is assumed. So TTV is non a pathogene or an orphan virus. The other features of TTV are that its immunological control involves all major immune compartments, the T cell or the B cell based compartments, and the other most important features of TTV are the resistance to conventional antiviral therapies and the association with the host immune function. And now this slide describes maybe one very most important feature of TTV. And this is a publication or a work published in Cell 2013 by the group from Stanford by Steve Quake. And here in the orange bar, the tiny bar, you can see the proportion of TTV at day 0, at the time of transplantation. And with the initiation of the strong immunosuppression, you can see that the replication of TTV increased rapidly, and TTV becomes the most dominant virus at month 3 post-transplant within our human virome. And TTV remains the most dominant virus with a slight decrease over the subsequent months. So here you can see the very typical TTV kinetic after transplantation. So this important work also highlighted other features of TTV, the dependency of the TTV load towards the tacrolimus dose. So we have higher TTV loads with higher tacrolimus doses, and as I already said, that TTV is resistant to conventional applied antiviral drugs like vanciclovir. And here on the right side, you could see that this work also was one of the first works who described a clinical correlation between low TTV indicating low immunosuppression and the occurrence of graft rejection. So this work really kicks off the whole field of TTV and also kicks off our field working on the hypothesis of TTV for risk assessment after transplantation. If TTV is very low, this indicates to low immunosuppression coming with an increased risk for rejection. And if TTV is very high, this indicates over immunosuppression coming with an increased risk for infection. And the hypothesis is that if TTV is between a specific range, maybe then also the individual immunosuppression is best balanced or best optimized. So on this hypothesis, we here in Vienna in our group under the lead of Professor Bond has made a couple of studies, and I'd like to present here maybe one of our most important trials, the TTV-POA trial. This was a non-interventional prospective cohort study including almost 400 kidney transplant recipients. The TTV load was measured using the in-house PCR at the day 0 at the first month, within the first 3 months, and then in 3 months intervals. And the primary endpoint was biopsy-proven rejection in 4-cause biopsies and host infection defined by the requirement of hospitalization, anti-infective therapies, or the reduction of immunosuppression. And the first finding was that we could confirm this typical TTV kinetic with a significant increase of the first 3 to 4 months, and then the stabilization phase between months 3 and 12. And for the analysis in this trial, we only refer to TTV between months 3 and 12 because we think that you can only use TTV when it's stabilized after day 90 to day 120. So in this analysis, then we just looked at the TTV prior to a rejection or non-rejection in the 4-cause biopsy, or prior to no infection, or prior to an infection event. And we came up with this very dynamic risk assessment. As you can see here, with the increasing load of TTV, the risk for rejection decreases and the risk for infection increases. looking first on the infection events, you can see that patients with an infection had significantly higher TTV values compared to patients without infection. And also here the risk ratio or the odds ratio indicating a significant increased risk for infection by increasing TTV load. And the effect size of this risk remained stable also in sensitive analysis for BK virus infection or CMV virus infection. On the other hand, in regards to rejection, patients with rejection had significantly lower TTV than patients without rejection in their biopsy. And here also the risk decreased significantly with increase in TTV load. And from this data, we concluded that the optimal range of TTV was between 8 to 6. And if TTV is between this specific range, also the individual risk for infection or rejection might be best or more minimized. So in this trial we have used the in-house PCR here in Vienna, which is based on the in-house PCR published by Professor Macci in Italy, who also is taking part in our TTV-guided DX project, and who is maybe the godfather of the TTV PCR. But since then, we found different ways to quantify TTV. You can quantify it in plasma, serum, whole blood, also respiratory material in urine. But in 2021, a commercial CE certified PCR becomes available. And this PCR by Beremeux is really promising in terms of standardization and comparability of TTV PCRs and results between different centers. So then in 2021, we have used this new available commercial PCR to validate our risk assessment. And in this validation study, we have analyzed 342 plasma samples and quantified TTV using the commercial PCR and the in-house PCR. And what you can see here in this Brandt-Altman plot is that both PCRs correlated quite well together, and that the commercial PCR quantified TTV with a little bit lower, with a median delta of 1.38 log. So then we also looked on the primary outcomes in regards of biopsy-proven rejection and infection. And we could confirm that our risk assessment for the first year post-transplant using now the commercial PCR, so that we have increased risk for infection by higher TTV and increased risk for rejection by lower TTV. And here the effect size for rejection was even higher due to the point that we could include more rejection events in this validation study. Here now the optimal range was between 6.6 log10 and 4.6 log10, and this was due to the point that we found this median delta of around 1.4 log between the in-house PCR and the commercial TTV Argine PCR. And this is the range of the TTV Argine PCR, which you also have published, which can be also already applied in individual clinical settings. How we came up with this range, for this we have to look here on the specificity and the sensitivity for infection or rejection, and below these thresholds, the specificity for rejection or infection becomes significant. But we really have to see that this is a quite dynamic risk assessment, and the optimal range may also depends on which question you want to answer. If you have a clinical question or research question. In a research setting, you might have to be more strict with your optimal range. In a clinical setting, you will be more flexible with your range. And this range also depends on the PCR you are using, and this the thresholds we have published here are also or can be only applied to the commercial TTV gene PCR in the first year post-transplant. So this data was only for the first year, but there's always the question, what about beyond the first year post-transplant? And here we have another clinical study from a group from France, and they have looked at TTV guidance in year 2 to 4 post-transplant. And this is a quite interesting study because they have created a discovery code in which they have defined their optimal range beyond the first year. And the optimal range here was between 5.1 and 3.75 log. And they defined this range, the higher limit with the occurrence of post-transplant complications like infections or cancer in the discovery code, and the lower limit was defined by the serological response upon influenza vaccinations. And then they used this specific range and tried to validate it in a validation code with 22 kidney transplant recipients. And TTV was measured using the commercial PCR at 1 year, 2 years, and 3 years post-transplant. And what they have seen in the analysis was that the patient who remained within this specific range at these time points, more than 50% were also these patients with a decreased risk for post-transplant complications like rejection, cancer, or infection. So this is first interesting data for the year 2 to 4 post-transplant, and this group is also working on the randomized control trial validating this long-term TTV-guided immunosuppression. So looking on long-term complication is always interesting, looking at the occurrence of malignancies after transplantation, especially in the regards of the immunosuppressive toxicity. And this is what we have done also for our TTV-powered cohort, looking at nearly now 600 kidney transplant recipients. And here we have measured the TTV load within the first year post-transplant. And we have calculated a TTV weighted mean between months 4 and 12 post-transplant using all TTV measurements within this time period. And the primary endpoint here was then the occurrence of malignancy, any type of malignancy in year 2 to 5 post-transplant. And what our model had showed is that TTV was positive correlated, associated with an increased risk for malignancy. That means that the higher the TTV was in the first year, the higher the risk for malignancy was in the years after. And this was independent by other factors like age, sex, smoking, or BMI. And in this graph, you could see that the cumulative incidence for malignancies were significantly higher in the patients with a higher TTV load or higher TTV exposure over the first year post-transplant. So this is unpublished data by my colleague Carsten Herz, and this is a very interesting first hint towards the association between TTV and long-term complications like malignancies. So using TTV, it is always very important to know how TTV reacts upon specific changes of my immunosuppressions. And here we have made an analysis of TTV after specific changes of the tacrolimus doses. And in this study, we have included 283 consecutive kidney transplant recipients, and we only looked at isolated tacrolimus changes. So the tacrolimus change, those should be changed at least by 20%. And then after the change, there must be a TTV PCR available 1, 2, or 3 months thereafter. The main exclusion criteria in this study were that the change of other immunosuppressants, the cases of severe leukopenia or severe CMV infections. And what you can see here is that the tacrolimus change by more than 20% becomes available in the TTV kinetic after day 60. It doesn't matter if you decrease tacrolimus or increase tacrolimus, the TTV load needs sometimes to reflect this significant change of your tacrolimus dose. So TTV is not reflecting short-term changes. It really can reflect or mirroring the long-term immunosuppressive exposure. It can say you something about your exposure over the last weeks to month. And if you want to see any effects of your CNI dose changes, it is advisable to measure TTV 2 or 3 months later. So this is our main immunosuppressive, or one of our main immunosuppressive medication, but what about others? And here we have an analysis about TTV upon the changes of the antimetabolites, mycophenolate acids. And this study was published by a group in Germany, in Heidelberg, and they have analyzed TTV in a cohort in the setting of kidney transplant recipients who received a COVID-19 vaccination. And to enhance to increase the chance for the COVID-19 vaccination response, they have paused the mycophenolate acid for 5 weeks. And TTV was measured at the time prior to the vaccination, 4 weeks after vaccination when MPA was paused, and 3 months after the vaccination when MPA was reintroduced again. And what they have seen is that during this 5 weeks MPA pause, the TTV load decreased significantly and significantly increased again after the reintroduction of MPA. And this data from this study is also in line with the observations and analysis we have made in Vienna. And we can conclude overall from this that a pause or stop of the MPA doses of 2 to 4 weeks may lead to a reduction of TTV by half a log. And also this change becomes available after 1 to 2 months. So you really need some time to see your immunosuppressive reductions in the TTV kinetics. So what are known determinants of the TTV load? So we have also made this analysis here in Vienna by my colleague Katharina Meyer, and we have found that there are common factors like the host age, especially higher age, sex, higher BMI, but especially the leukocyte counts have a significant impact on the TTV load. Of course, as I shown previously, the amount and the type of immunosuppression or immunomodulators can have a huge effect on the TTV load, but since then or until now we don't have significant or sufficient data for mTOR inhibitors. And there's also a lot of questions which have to be answered regarding CMV and TTV. This is just a personal communication, but we think there might be some type of interaction, especially if the CMV is really high, because what we see in our daily clinical routine sometimes is that if CMV is very high, TTV might to decrease, and this might be to the fact that both viruses somehow are in concurrence of their replication sites or resources. But this is just a personal opinion, and we really need more research to investigate the interaction between TTV and the CMV virus. So what about other important immunosuppressants? And here we have data for belatacept. Previously, prior to this data, we always thought that TTV is quite sky high in belatacept patients. But here we have now very well done studies from Leiden and Grenoble, and here you can see the TTV kinetic after the switch to belatacept from a DNA-based immunosuppression. And here we can see that the TTV kinetic remains stable after the switch. Maybe here we have a slightly increase, but this wasn't significant. So the conclusion from this study is, might be that we can also use the TTV guidance thresholds for belatacept-based regimens. So all this data and studies I've shown you so far is very academic information. Now I really like to give you a little bit more practical information, and I have prepared 2 case reports from our clinics, and here I like to start with one which was a very older patient, a male, 4 years post-transplant, was a living donation. And in green, you can see the TTV kinetic over time over the years post-transplant. And you can see here that in green, the optimal range for the commercial PCR, and that after year 2, there was a significant increase of TTV, and the patient remains in very high TTV levels, indicating over immunosuppression. Looking now on the tacrolimus levels, there was, of course, some variability of the tacrolimus exposure over time, but we can also see that the tacrolimus doses seem to be higher within year 2 and 4 post-transplant. But looking on the scale here, all levels were somehow in an acceptable range. But what was a problem in this patient is that he had a series of respiratory infection in this time of over-immunosuppression, leading to a severe case of pneumocystis pneumonia. And this infection led to prolonged hospitalization, and received severe anti-infective treatments, also including immunoglobulins. And with this event, we decided to decrease the immunosuppression significantly. And this treatment decision, you can see is reflected by the TTV load, by this significant decrease in TTV after the decision to reduce the immunosuppression. And with the reduction of the immunosuppression, also the patient had stabilized and had less infection events thereafter. So here you really can see your effects of your immunosuppressive reduction, and you can see, or you have a kind of infection control that you really want to see, that you go down with your risk for other infection events. So this is another case report, somehow very different than the other one. And here we have a young patient, 1 year post-transplant, also a living donation, preemptive transplantation. So these are very good good conditions for a successful transplantation. And once again, here in green, you have the kinetic of TTV over the first year post-transplant. And at the start, we have this significant increase of TTV up to day 80 to 90, but then TTV decreased significantly again and remains very low over a long period of time, especially looking at our optimal range. So here is a period of under immunosuppression indicated by TTV. Looking now on the tacrolimus levels, you can see that it's quite follow well the TTV kinetics, but actually the tacrolimus levels were somehow in a quite acceptable range again. But this patient came to our outpatient clinic at month 11 and had a very sky-high serum creatinine of up to 20 milligram per deciliter, and of course we transferred him to a biopsy, and we found a mixed severe graft rejection leading to graft failure. So a very dramatic case actually, and the problem of this patient was non-adherence. And looking now on the TTV kinetics, you can see here that this non-adherence leading to under immunosuppression is well reflected by TTV, and this time period of 9 months potentially had provided us more time or more room for intervention to enhance to work on the issues of non-adherence issues of this patient. So non-adherence or TTV might be also a tool to indicate clinically significant non-adherence. And this is a very interesting question we're also working on in the ADHOC trial, which is a combination of a comprehensive adherence monitoring using different state-of-the-art tools like the BASIS questionnaire, electronic drug monitoring, pharmacy refill records, individual evaluation by cytological evaluations, or the interpatient tacrolimus variability. And all these adherence tools were then combined with our immune monitoring based on the quantification of TTV. And here we have very preliminary data from this trial. And in the red line, you can see the TTV kinetics over the first year in patients who were multiple times non-adherent by the BASIS questionnaire. And these non-adherent patients seem to have lower TTV than the patients who remained always adherent. So this is one first hint towards this association of low TTV and non-adherence, and we're really working on the analysis of this trial and try to figure out the triangle between non-adherence, post-transplant outcomes, and in between TTV as an immune monitor or immune marker. So let's summarize the evidence over the recent years. The interest and the activities on TTV as for immunosuppressive guidance has increased continuously, and we have most data evidence for kidney transplantation followed by lung transplantation, and only minor data for liver and heart. But all published papers, which we have summarized in this narrative review published in Transplantation 2022, came up with the same, or reconfirmed our association of low TTV and the risk for rejection, independently of the type of rejection, RBMR, TCMR, borderline, late or early, subclinical, or by for-cause or in for-cause biopsies. And we also, there's a strong evidence for the association between high TTV and the occurrence of infection. So what is the pipeline for such a non-invasive biomarker? As I have mentioned, now we have a lot of quite robust and significant evidence from observational, mostly single-center studies. But the TTV really finds its way into our clinical routine. We really have to prove its clinical value in randomized controlled trials. And this is also now the time for TTV-guided immunosuppression. Therefore, we have designed the TTV-guided trial, which is a randomized controlled trial looking at the safety and efficacy of of TTV-guided immunosuppression after kidney transplantation. And to conduct this trial, our group, under the lead of Professor Bond, received a EU-funded grant within a Horizon 2020 project. And in this project, we have came up with a huge consortium with 19 partners all around Europe. And from these 19 partners, we had 13 centers, clinical centers, recruiting patients for our randomized trial. What is the timeline of this project? Our project has started in May 2021, and in the first phase of the project was really about preparation and implementation, especially the implementation of the commercial PCR. Firstly, we have conducted the validation study of the optimal TTV range using the commercial PCR as the result I have shown you before. And within this time period, we also implemented the commercial PCR at all 13 trial sites. The actual TTV-guided trial then started in August 2022 with the first patient, first visit here in Vienna. Also in this time, we have conducted or implemented a quality assessment of the TTV PCR, which continues over the clinical phase of our trial. So let's go to the clinical features of our TTV-guided trial. As I mentioned, this is a multi-center, non-inferiority randomized controlled trial, a phase 2 trial, really focusing on the safety of TTV-guided immunosuppression. We have these 13 centers all around Europe recruiting 260 kidney adult transplant recipients. All of these recipients were of low immunological risk, and this risk was also estimated within the screening phase of the first 3 months post-transplant, and then all of our patients which were eligible for randomization were randomized at month 4 post-transplant. And then these patients were assigned to the intervention group, and the control group. What is the primary outcome in our study? It's a composite endpoint by the occurrence of infection, allograft rejection, graft loss, or death. Also, we have included main secondary outcomes, and here are the most interesting ones for me: the tacrolimus levels over time, the 12-month protocol biopsies, which are a very important safety factor, the renal function over time, the occurrence of adverse events and serious adverse events, very crucial safety features. And we also really try to include the patient perspective, looking at patient-reported outcome measurements like health-related quality of life or the side effect burden which comes from our immunosuppressive medication. And also medication adherence is quite an important topic within the TTV-guided trial, which was measured or which is assessed by the basal self-reports and electronic monitoring tools. So here you can see the actual trial plan of the trial. As I already mentioned, we have the 3 months screening phase, then the randomization within month 4 post-transplant, and then we have an intervention phase with 6 study visits within 6 weeks intervals. And then we have a last study visit after the first year post-transplant, which is a follow-up visit. So in this next slide, we can see the detailed description of our TTV-guided intervention. In the active interventional group, we measure TTV every 6 weeks. And if TTV is above our upper limit of 6.2, the target of the tacrolimus dose will be decreased by 1 step and one step is defined by 2 nanograms per milliliter. On the other hand, if TTV is below our optimal range and below the limit of 4.6 copies per milliliter, the target of the tacrolimus dose will be increased by one step if the patient remains adherent. If TTV is within our optimal range, then the tacrolimus target will be defined by the actual tacrolimus level. Instead, in the control group, there is no TTV guidance, and the tacrolimus target and the tacrolimus dosing will be conducted by the local center standards, and this mainly refers to the Elite Symphony recommendation that the tacrolimus levels should remain stable between a range of 5 to 7 nanogram per milliliter. So, how our TTV guide project and the guided trial continues. So, as I said, the first patient was included in August 2022, and the last patient, randomized patient, the last randomization was then 2 years later in August 2024. And we were really happy to reach our anticipated target of randomized patients. And now we can assume that the last patient, last visit, and actually the end of the clinical phase of our trial will be in May this year. And I hope that then we can analyze our results in October 22, and thereafter the publication will follow in 2026. During the whole trial, especially during the clinical phase, I already mentioned that we have this quality assessment. And I really like to mention shortly the main results from this quality assessment. And in this slide, we have analyzed more than 1,000 TTV measurements in all clinical labs all around Europe. And we came up with a very low inter-laboratory and intra-laboratory deviation between all labs. And this is a quite huge achievement from this trial, that we really can confirm that all labs all around Europe measured the same amount of TTV. And of course, there are some differences, and we have to account this difference by comparing this with other virus measurements. This is a very huge achievement and confirming a very high level of standardization and comparability of our TTV measurements. And all of this data is already published last year. So until now, I just have presented about the field of transplantation. But the travel and the journey of TTV continues, and there are more and more clinical fields which has gained interest to use TTV to personalized immunosuppression or the immunomodulative therapies. And I already mentioned the interesting field of adherence, but I like to give you now other examples from the field of vaccinations and autoimmune disease. Here we have a really interesting study, also analyzed in Austria, but conducted in German kidney transplant recipients. Here in this, we have in this study, the serological response towards the COVID-19 vaccination was analyzed. And TTV was also measured before the first dose of the vaccination. And low or a very high TTV was then associated with an impaired serological and cellular response towards the COVID-19 vaccination. So concluding from this data, we might say that we can use TTV to steer the immunosuppression for a better response of the vaccination. That we maybe have to decrease or reduce immunosuppression. The TTV becomes below the threshold of 4.6 log by the commercial PCR, and then we might have a better response towards this vaccination, and after vaccination, the immunosuppression can be increased again to common levels. So this is the next example from the field of autoimmune disease, especially from the setting of rheumatoid arthritis. And in this study, also published by colleagues here from Vienna, they have analyzed TTV after specific DMARDs therapy. And it doesn't matter if they applied co-stimulation blockade, anti-TNF therapies, or anti-CD20 antibodies, rituximab. TTV increased rapidly or significantly after 3 months. And the significance was most obvious for the therapy with rituximab. TTV is here indicated by the green bar after 3 months. And another very interesting finding from the study was that the patients with within the highest quartile of TTV was also this patient with a significantly better treatment response compared to patients with low TTV. So if TTV remains low, also here these patients might have a decreased or impaired response and maybe need more doses of the treatments or prolonged treatment durations. And there's a very interesting potential to use TTV guidance in immunosuppressive therapies in AI. And this is other question which is currently investigated by another EU-funded project, the SQUEEZE project, which is also led by a research group from the Medical University of Vienna. So with this slide now, I'd really like to sum up my talk and give you the main information about TALK rhinovirus monitoring for immunosuppressive guidance. So once again, TTV is an SN single-strain DNA virus from the family of the adenoviruses. It's highly prevalent after kidney transplantation. Until now, it's not associated with any kind of disease, but it might be a potential surrogate marker for host immune function after kidney transplantation. We have compiled this risk assessment here using the commercial PCR, which can be already applied in the individual cases in the clinical routine. And this risk assessment is now investigated in our randomized trial, really looking at the safety and efficacy of TTV-guided immunosuppression. And more there will be more potential applications using TTV as an immunological monitoring. And I really like to highlight here the field of medication adherence, vaccination, autoimmune diseases, and also oncology will follow soon. So about our holy grail, personalized immunosuppression, I think we'll always look at our patient. What is the immunological profile of our patient? And what is the clinic of our patient? What about the occurrence of post-transplant complications? And I think we will always look on the drug levels, of the tacrolimus levels, on the dosing, over the variability over time. But I think for enhanced personalized immunosuppression, TTV might be one additional tool, one additional puzzle piece, which will help us to find the best balance dosing of our immunosuppressive medications. And I really hope that we, with our trial, we can come closer to a more individual approach to dose our immunosuppression. So all information about our TTV-guided trial and all our information about TTV as a surrogate marker for the immune competence and immune function can be found in our TTV guide internet website. You can scan this code, or you just look at TTV-guided.eu. There you can also find very interesting videos. And here's once again the summary of our randomized trial. And with this slide, I'd like to thank you for your participation, that you come here to our webinar. And I'd like to say thank you, especially on behalf of our project leader, Professor Bond, and the whole group here in Vienna which is working on the TTV field. And I really also like to say thank you on behalf of the whole consortium, including all partners all around Europe.